All right, we're gonna get going again. We're gonna start the kidney, everyone's favorite. So if you need to like do a big stretch or power pose or whatever you'd like, or if you love the kidney, then good for you. Awesome. We're going to talk about kind of three major areas. We're going to go through nephron molecules and what's going in and out at each stage and part of the nephron, that small little microscopic structure in our kidney. We're going to talk about acid-base balance and what happens when we get into metabolic or respiratory alkalosis or acidosis and what that looks like, how the body responds, things of that nature. We're going to talk about nephritic and nephrotic syndromes. It's our favorite thing that we confuse. And we'll get down to that pathology. I think that's at the end. I think there might be something in between, but we'll cover it all. So to get us started, to kind of make sure we're all on the same page, we're just going to look at the anatomy of a nephron here. Again, remember, we're looking at the microscopic anatomy of a kidney. So we have Bowman, we have our arterioles that come from our renal artery that's coming in here. Our arteriole that comes from the glomerulus that's coming out, right? So we have blood flow going in and blood flow going out, right? Our glomerulus right here, encirculated by Bowman's capsule on the outside. If you think of your glomerulus and your Bowman's capsule as your big filtration system, it starts up your filtration process, filtering out things that are large or small, deciding what's going to flow through the nephron in the first place. And then our nephron is just our huge concentrating system for urine, right? So we're going to take us through we have 4/5 main structures or tubules, and each different structure or tubule is going to filter in or out certain structures or components. So we start with our proximal tubule. So that's this kind of crazy thing up top at the beginning. We go down our thin ascending loop of Henle, up our thin descending loop of Henle, up our thick ascending loop of Henle, down and up. Then we hit our distal tubule here, and we move into our collecting duct. Oh, we are going to talk about the renin system too. That was another thing. We're going to hit it all, like I said, all the kidney. So our proximal convoluted tubule, referred to often as PCT. This, if you're into like looking at biochemical schema of what's happening, there you go. But essentially at this brush border, it's going to reabsorb all of our glucose and our amino acids. And I do mean all, it's going to take in all glucose and amino acid that's there. And then it's going to reabsorb most bicarb, sodium, chloride, potassium, water, uric acid, and phosphorus. So really, this is our big absorption center. We are trying to maintain and keep as many micronutrients, as many of our minerals and electrolytes as possible. And it all starts with the proximal convoluted tubule. So when in doubt, the majority of your sodium is reabsorbed here. Water is also reabsorbed here. And aside to keep in mind, our parathyroid hormone at this point can inhibit our sodium and phosphorus co-transport. We remember parathyroid hormone is going to help maintain our calcium, phosphorus, and vitamin D balance in the body, really supporting bones, right? Phosphorus and calcium, huge parts of our bone metabolism and balance. So that all starts at the kidney. So that's when you can see the kidney as not an endocrine organ, but has some endocrine organ function as a secondary endocrine organ, because parathyroid hormone directly affects this area. I told you, endocrine and neuro, it comes into every single system in the body, right? As those factors of control. So again, if you like, oh yeah, go for it. Yeah, so it's going to, we have co-transport here, which means they're going in the same direction. So it's actually going to promote reabsorption of sodium and phosphorus in the same direction. Yep. Anytime I say co-transport, we're moving in the same direction versus like anti-transport or opposite or exchange opposite directions. So sodium and phosphorus are going to be both absorbed in the same direction by parathyroid hormone. So it's going to inhibit. Oh, I get what you're saying because I said inhibit. Yes. Thank you. Yeah, it's going to inhibit release or removal of sodium and phosphorus, parathyroid hormone. So it's going to encourage reabsorption, inhibit our elimination. And again, when we're talking about elimination and reabsorption, we have to remember that we're talking about the cells here in the middle, proximal convoluted tubule. We're talking about reabsorbing things from the lumen, from urine side, right? So this is the urine concentrating side over here. So when we're reabsorbing, we're moving things from here to here and then to our bloodstream. When we're secreting things, we're moving them in the opposite direction. So from blood to cell to our urine, or we're just keeping them in the urine for secretion. So here you can see the body keeps sodium in exchange for some hydrogen, so exchange for a proton. It then hangs out with bicarb in here, and you have your carbonic anhydrase comes back into play, and you have some CO2 produced, which is actually reabsorbed. And so you have this little process that goes here, and that's how bicarb neutralizes some of the acidity of the urine. But because your body is trying to hold on to so much sodium, you do have more acidic urine, and that's thankful to our sodium reabsorption process in exchange for hydrogen ions. You'll see this throughout urine. You'll see lots of times we're exchanging a hydrogen ion in exchange for some type of metabolite that we want to keep. That's why urine tends to be more acidic, right? Unless if we're in pathologic state. We also then see sodium is being pushed into our bloodstream in exchange again for hydrogen. So when in doubt, proximal convoluted tubule reabsorbing almost as much as it can. Then we get to the thin descending loop of Henle. And this picture here kind of just shows you again another schema of just a different way of representing the kidney and the nephron as a whole. You have, just to orient you, your renal corpuscle with your nephron, your glomerulus, your Bowman's capsule. You then are in your proximal convoluted tubule, your loop of Henle down and up, your distal convoluted tubule, and your collecting duct. And it's trying to show what is being reabsorbed here. So these arrows are showing what your body is taking out of the lumen and into your normal concentration. So when we're in the descending limb, the thin descending limb of Henle, or loop of Henle, we're mainly doing passive reabsorption of water. That's our main thing that we're reabsorbing. We cannot absorb sodium in this section. So this is one area, the only area that we can't reabsorb sodium is our thin descending loop of Henle. It's going to make our urine, what's staying in the lumen, hypertonic or more concentrated because we're pulling water out. So if you're talking about wanting to concentrate urine, or if you're having trouble concentrating urine, this would be an area you might look to, as is there something wrong with my thin descending limb? Because this is where I should be reabsorbing water and making my urine more concentrated. It has no effect on sodium. Yes. Correct. Aldosterone is going to hit your collecting duct. Yep, your collecting tubule duct. So this is passive. This is just moving in the direction of osmosis. So our right now we're seeing that there's more water present in the thin ascending or thin descending loop of Henle than there is in blood. So the concentration of water is higher in the lumen than it is in blood. So it's a passive process of osmosis. Water is leaving. Another way to say it is there's more sodium concentration in our blood than in the lumen. So water is going to leave down that gradient. So it's passive osmosis. No active transport occurring here. Now we get to the thick ascending loop of Henle. Our thick ascending loop of Henle reabsorb a decent amount of sodium here. So sodium reabsorption begins again. About 10 to 20% of sodium reabsorption occurs in the thick ascending loop of Henle. We also reabsorb potassium and chloride. So again, to orient you, this is your lumen, this is your blood. Lumen meaning where the urine is. So we're taking in potassium, chloride, and sodium into the cell, and then chloride and potassium are moving through a sym port together. Potassium is also going to passively move. And then we're using an ATPase to move sodium out in exchange for more potassium in. This process works because potassium tends to be more leaky to our cell membranes on this blood side of the cell. So we have leaky potassium leaking out, and that allows us to have a concentration gradient. So we want to bring potassium in to fix that leaky gradient And then we're able to get our sodium into our blood. And we're using some ATP, some energy. There is indirect absorption of magnesium and calcium, but those little ones, they go between the cells. That's why it's called paracellularly. So you can see magnesium down here. You can put calcium with it. They're going to absorb in between the cells. So they're not going directly through the cell. They're not going directly through a transporter. And that's via the gradient generated by our leaky potassium. So there is a electrochemical gradient, and so it pulls some magnesium and calcium through. So again, that's why the kidney, and that's why blood volume and concentration is so affected by potassium. Hypokalemia, hyperkalemia. When that potassium concentration changes, it not only affects our blood volume, blood pressure, but it also directly affects what's being pulled through in certain areas of your kidney nephron, specifically your thick ascending loop. If you don't have that gradient, you're less likely to be able to pull magnesium and calcium, so you could see deficiencies in both of those. So when you get to farm, I think all of you have already taken cardio, but when you have to really kind of put those things back into your brain, right? We talk about all of our different diuretics. That's why you can see hypokalemia and hypomagnesemia and hypocalcemia, and they can all start occurring if you're dumping potassium, because we need this gradient to be present. Welcome. You wanted to join the kidney discussion. I knew it. The best part of the day. This part, while the thin descending loop was impermeable to sodium, the thick ascending loop is impermeable to water. So they're opposite. This means that our urine becomes less concentrated. So we just concentrated our urine, and now we've unconcentrated our urine, right? We've now reabsorbed all these nutrients, when before we had just reabsorbed all this water. Then we get to our distal convoluted tubule, our DCT. This reabsorbs even less sodium. We keep going down. The further we go, the less sodium we reabsorb, because there's less present for us to actually take back in. We've done a good job so far. So we reabsorb sodium here, we reabsorb chloride here. They move together from the lumen. So you can see sodium and chloride, they can move in the same direction. This is going to be the step that we make our urine fully dilute, hypotonic. We're also going to see, you see again, we have our sodium, potassium, ATPase pushing sodium into the blood. When in doubt, that's what's happening, getting sodium from the cells. And our parathyroid hormone attacks here again. It's going to increase our calcium reabsorption via a calcium sodium exchange. So it's not on here, but what it's going to do is it's going to take calcium in, and then it's going to exchange for some sodium out, but then sodium and chloride can come into here together. So you're not pushing sodium back into your actual lumen. You're reabsorbing calcium in exchange for sodium, but then sodium and chloride get to come through here at the same time. And then here you're going to actually, chloride just goes through passively, and then sodium and potassium have their exchanger. Calcium has its own transporter. But that's how the bones can affect. So if you were going to be asked a question about parathyroid hormone and the kidney, the two main areas it affects are the proximal and the distal convoluted tubule, and it's going to affect calcium and phosphorus absorption in exchange for sodium. Going the same direction in one and opposite directions in the other. Yeah. Yes, correct. So you think about it as we have, oh, I've written a lot of weird notes today. Okay. We have lumen with urine, cell, blood, and we're going to be in the, ooh, that's fun, distal, oh no, proximal, are we in the proximal? We're in the proximal, nope, distal, that's right, distal convoluted tubule. So we're going to have calcium going here in exchange for sodium here. And then we're going to have sodium and chloride going here. So you have a net gain. And then sodium is going to go out. Potassium is going to come in. Chloride just gets to go on its own. And then calcium is also exchanged for sodium here, which is why you have to do this ATP pump to get net sodium out. This is energy, one here. Passive, passive energy. Yes, no, maybe so. Yeah. Okay. And how I would study these sections, I would draw out lumens and I'd put arrows. One thing goes one way, one thing goes the other. The nice thing about the proximal convoluted tubule, everything's trying to reabsorb, right? You want to keep it all, except for hydrogen. It's the only thing you get rid of. You have acidic pee normally, except for with what bacteria? Ooh, recall. What bacteria makes pee alkaline? Proteus mirabilis. Yes. Done. Micro. Got it. We'll talk about Monday. That's just one. But we got this. Okay, collecting tubule reabsorbs 3 to 5% of sodium in exchange for potassium and hydrogen. Aldosterone regulates this. This is our aldosterone regulated zone, is our collecting tubule. It's also our antidiuretic hormone regulating zone, but in a different way. So we can see here also, so like I mentioned, antidiuretic hormone is going to insert more aquaporin water channels on the apical side, urine side of the membrane. And it's also going to increase urine or urea reabsorption. So antidiuretic hormone increasing actually these receptors for water on the apical side. That's how it's going to reabsorb more water from increased antidiuretic hormone secretion. Versus aldosterone is directly, aldosterone right here, is directly affecting the exchanger of sodium, potassium, and hydrogen. Now, sodium and water play together, right? So you do have reabsorption then of water too, but it's not because of increased channels. That is only antidiuretic hormone that increases your aquaporin. So big thing for collecting tubule, it's only being affected, it's sodium in exchange for potassium and hydrogen. So sodium getting reabsorbed, we're kicking out potassium and hydrogen in exchange, which is why if we have aldosterone that's increasing sodium absorption, we're gonna have lower potassium. So that's why when we had high aldosterone, we had hypokalemia and high blood pressure. Yes. Yes. It's going to move into the blood via a transporter of some type, most commonly via a potassium sodium exchanger using ATP. There's some that will go via down like a concentration gradient via natural diffusion, but it's not going to stick around in a cell for that long because it's really an extracellular ion. Your potassium is really what's hanging out in your cell, which is why once sodium gets there, it's okay with exchanging for potassium because potassium is in high concentration typically in a cell. So the cell wants potassium, so it's okay to kick out sodium to get potassium back in. Yeah, absolutely. Good question.
This is from Zoom. Are there any pathologies that directly affect the distinct portions of the nephron?
Yes, we're going to talk a little bit about nephritic, nephrotic syndromes here later on today, and they will have some direct effects on certain components of like absorption, secretion, those type of things. Also, any of your IgA or immune-generated glomerulopathies can affect the nephron. So we will talk about some of those pathologies today. And then, of course, anything that's going to affect blood pressure, blood volume is going to change how we're concentrating our urine. And then if we have any issues with genetically with these different symporters or transporters. I'd say for unplex, your big ones that you want to know, which is why we're gonna actually walk through them, is nephrotic and nephritic syndromes, and understanding how those can affect the different components of the nephron and absorption and excretion of nutrients. Okay, great, awesome, thank you. So again, just a little review without you getting to look, so don't cheat. Okay, We have our proximal convoluted tubule. We have our loop of Henle. We have our distal tubule, and we have our collecting duct. Which portion of the nephron has the highest concentration of sodium reabsorption? The PCT, absolutely. Number one, the PCT, good. Which portion of the nephron is impermeable to water? Or which, let's do this one first, then I think you'll get the other. Which portion of the nephron is permeable to only water and not sodium? The loop of Henle, which part? Descending loop of Henle, permeable to just water, nothing else. Then what portion of the nephron is not permeable to water? Ascending loop of Henle, exactly, good. Where would aquaporins go? In the distal convolute or the distal tubule or the collecting duct. Sorry, the collecting duct, absolutely. I'm using myself, yeah. Collecting duct. And what hormone causes those aquaporins to increase? ADH, antidiuretic hormone, good. What other hormone affects the collecting duct? Aldosterone. Which section of the nephron tries to absorb everything? Proximal convoluted tubule, perfect. Where are the two sections that the parathyroid hormone affects? And distal, good. That's how you can say these things. You just have to do some repetition with these components. Recognize in general, the proximal convoluted tubule is trying to absorb everything. It absorbs the most sodium. It's really only kicking out hydrogen ions, right? It's really only exchanging hydrogen ions. It's net exchange. Our thin descending loop of Henle is just dealing with water. It's taking back in water passively. Our thick ascending, no water. It's getting back in some more sodium, some potassium, some chloride. And our distal convoluted tubule is just mopping up the rest, right? It's doing a little bit more sodium reabsorption. Some extra ions are passing through there, but it's getting us ready to go into the collecting duct, which is our final stage in getting our urine concentrated for excretion. Okay. It doesn't have to be hard. We just make it that way. Okay. I swear it does not have to be hard. We just make it that way. All right. Huh? Love him. Yes. Love him. Love him. Yeah. There's so many things to know, right? We could know every single symporter and transporter, but is that going to help us as a naturopathic doctor or a doctor in general? No. Would that help us as a nephrologist? Maybe. Still probably no. Do we need to know which ions go in and out? 100%. We don't need to know the exact ATP energy exchange, unless if you're going to do a dissertation on nephrology, which I don't plan on ever doing. Okay. All right. The renin-angiotensin aldosterone system. Like I said, I just combined all these into one presentation. So there's like 4 presentations in one, just so we can kind of push through. We'll see how far we get. If we really start fatiguing, we'll take another break. If not, we'll try to just push through to the end, but we'll kind of, I'll test the room. We'll see where we're at. So I promised, and here we go. Renin-angiotensin aldosterone system. So we're going to walk through a couple pictures together, and then we're going to break down certain key factors of this process. So we've talked about this process, and I apologize, it's a little blurry. But we've talked about this process before when talking about regulation of blood pressure, blood volume, right? So things to keep in mind. We're going to start here, and we're going to kind of walk through this page. If you learn one process or one pathway, this would be a good one to learn, like this page in particular. The next one's going to really focus on its effects on blood pressure. So this is the system as a whole. Then we're going to look at what it's doing specifically to blood pressure. So our liver produces our angiotensinogen versus our kidneys producing renin. Important distinction to make. Renin, when present, is going to activate angiotensinogen and convert it to angiotensin 1. Right? The lungs then produce ACE. ACE is then going to be what converts angiotensin 1 to angiotensin 2. It's going to occur in the pulmonary system and in renal endothelium. So this is occurring in 2 locations. This is why if we take an ACE inhibitor, it can affect blood pressure, right? It's because we're directly inhibiting this conversion process here. So blood pressure can be affected by ACE inhibitors. Also be affected by ARBs. So that's where these medications come into play. It's also why there's this connection with an ACE inhibitor, taking that medicine and a cough, because ACE is produced in pulmonary tissue. So we can actually affect pulmonary tissue as well as renal tissue when you take a medicine inhibiting that enzyme. Then angiotensin 2 is really your active molecule. So everything until this point is kind of setting us up and doing these conversion steps. And then angiotensin 2 is really where everything gets affected by. So if we have a stopping point in any part of this process until we get to angiotensin 2, we're not necessarily going to see an activation of all these processes. So again, if we have a stopping point, if we don't get renin produced, then we can't get to angiotensin 1. If we don't have ACE, we can't get to angiotensin 2. If we have so anything upstream that's occurring and we can't get downstream, we're not going to see the effects of this system to its full extent. And there is some negative feedback loops that occur. So once we get to angiotensin 2, we're going to see an uptick in sympathetic activity. We're going to see an uptick in sodium and chloride reabsorption and potassium excretion. We're also going to see increase in water reabsorption because water tends to follow sodium, right, due to osmosis. On the adrenal gland cortex, we're going to see an increase in aldosterone secretion. Why do we think we see an increase in aldosterone? What does aldosterone do in the collecting duct? Increases blood volume, so it's going to increase what 2 things mainly? Nutrient-wise, salt and water, right? So aldosterone is what's helping us do some of that tubular reabsorption of sodium and water. Great. And if we remember, sodium and chloride get to transport together. And the reason we have an exchanger is because in the collecting duct, we actually exchange for potassium, right? And that's where a lot of this action with aldosterone is happening, is in that collecting duct. Okay. We also have arteriolar vasoconstriction, which increases blood pressure. This also will happen locally at the arterioles in the kidneys. So the afferent and efferent arterioles will be affected by this. So you'll have increased pressure flowing through the kidney then, the glomerulonephrosis, glomerular apparatus. You're going to have the pituitary gland, you're going to increase your antidiuretic hormone secretion. So you're going to increase aquaporins, which also increases water. And so you have a great reabsorption of water, a great increase in blood volume, because at the end of the day, when the system is activated, it's trying to correct blood volume to keep your brain pumping, to keep you alive, right? It's trying to make sure you have enough volume to perfuse all your tissues. So it's going to take in as much water, as much salt, vasoconstrict to push as much through a small tube as possible so it can be adequately perfused. That's what this system is doing. So when it can help save your life is when you have if you're bleeding out, right? If you had acute hemorrhage, either GI hemorrhage or acute trauma, your blood volume goes low. This is going to try to increase your blood volume as much as possible by pulling in water and sodium to keep you perfused. If you're going into shock, if you have hypotension, then when it goes bad, which we see, we try to block it, right? In hypertension, systemic hypertension. Once water and salt retention occurs, there's chemo and pressure baroreceptors that can measure and monitor these things. It's going to send negative feedback to tell the kidney to stop increasing renin production, which then will stop the cascade. It's measuring this perfusion specifically at the juxtaglomerular apparatus, the JGA. So that's where those afferent and efferent arterioles will measure the pressure differences. So if the concentration, the pressure coming into those apparatuses is increased enough, it'll then say, oh, we don't need to increase renin secretion. We can stop that now. And then this process ceases to occur. So it's a normal negative feedback system. So specifically looking at, okay, let's look at just blood pressure and the renin angiotensin aldosterone system, RAA system. So we see maybe a state of dehydration, sodium deficiency, or hemorrhage. So we have low blood volume, low blood pressure. That's our stimulus. Then we're going to say our juxtaglomerular cells of the kidneys are going to notice that, and they're going to increase secretion of renin. Our liver is producing angiotensinogen all the time. When angiotensinogen sees renin, then it converts to angiotensin 1, which will act on the lungs to produce angiotensin converting enzyme. That's what ACE stands for, which then produces angiotensin 2. Like I said, this occurs in the lung tissue. It also does occur locally in the kidney. Then our angiotensin 2 is going to have all these different actions like we talked about. On the adrenal cortex, it's going to increase aldosterone, which is then going to increase sodium and water reabsorption and increase secretion of potassium and hydrogen into urine. This reabsorption of sodium and water increases blood volume, which helps increase blood pressure. We're also going to see direct vasoconstriction of arterioles, which increases blood pressure. Once potassium increases in extracellular fluid, if we had a hyperkalemia, that would also trigger the adrenal cortex to increase aldosterone and to get rid of potassium. So we can see some local stimulation if we do have a hyperkalemic state that can also affect this adrenal cortex in the same way. But as we see here, this isn't affecting the renin-angiotensin aldosterone system from the top. It's affecting it directly at that aldosterone stage. Okay, how are we doing? So far, okay? Big Pete's, kidney, renin, angiotensinogen, liver. Renin converts angiotensinogen to angiotensin 1. ACE from the lungs converts angiotensin 1 to angiotensin 2. Angiotensin 2 does all the things, right? You got that down? You know RAA, you know the system.
Dr. Petro, this is from Zoom. Is there a physiological reason why the lungs are involved in blood pressure regulation?
The lungs is where ACE is synthesized. So that's why it's involved. It's because the lungs is the primarily the location that ACE synthesis occurs. It occurs in a small amount in the kidneys, but a large amount in the lungs. So that's why it's involved, is really for the reason of that enzyme is created there in lung tissue.
Do you know what the physiological reason for why that
It's there.
enzyme might be made in the lungs and has to travel so far to
So it's
send
made in lung,
signals?
partially made in lung tissue. I don't know why it started to be made there, just like I don't know why many things are made in different locations in the body. But I can tell you that it does have some factors and some effects on lung tissue that can be supportive. So it can help with some perfusion and lung states. It can also help with some surfactant production. So there are some likely other reasons for it to be in the lungs because it has other actions besides converting angiotensin 1 to angiotensin 2, but those aren't its main action. That's my best guess, but I don't have a solid answer for you.
Okay, thank you.
Yeah, absolutely. Good question though. I want to know too. Look into it. All right, now I want to go a little deep dive into a few of these different components, just so we have a little bit more breadth and information about them. This might also help with the ACE question. So renin, like I mentioned, is secreted by the juxtaglomerular cells. It's increased due to decreased renal perfusion pressure, right? Low blood volume. Afferent arterial detects that. It's also increased due to renal sympathetic, not disorder, but it's increased due to a beta-1 effect, a beta-1 adrenergic effect of the sympathetic nervous system. It decreases sodium chloride delivery to macula densa cells because it's increasing our sodium chloride reabsorption into the blood. So overall, renin release, this massive craziness. Juxtaglomerular cells is the main thing I want you to remember with renin release. You're going to have increased secretion when you have low blood volume. There's a beta-1 adrenergic effect that's associated, and you're going to increase sodium chloride absorption. Therefore, you're going to decrease delivery to macula densa cells. So it's going to go directly into blood. ACE, this maybe will be helpful. It is not just located in the lungs. So this might help answer your question. It's primarily created in pulmonary tissue, but and that's where the conversion occurs the most, but it's local to many other places, which is why it can happen in the kidney, it can happen throughout the body. And it's produced or provided by the vascular endothelial cells in the lung. That's who produces it. So this might help a little bit answer the question that we had online. Yes.
Yes, thank you.
Yeah, absolutely. I thought it was coming, but I wasn't sure when. Yes. Correct. So, because if we're trying to, if you think about what sympathetic tone does, right? Sympathetic tone, our goal with being in a sympathetic state is to have as much blood perfusion everywhere in the body as quickly as possible, right? So vasoconstriction, increased heart rate, elevated blood pressure. So renin, that renin system is a great way to do that. So anytime we're having a sympathetic state, our body is saying, oh, I need to promote blood vessel constriction and blood pressure increase so I can get adequate tissue perfusion. Absolutely. Yeah. Yes, absolutely. So as our macula densa cells and the cells in the juxtaglomerular apparatus, they're going to start, they have chemoreceptors on them. And if they notice there's a decrease amount in sodium chloride going to them, there's going to be an increased amount going through the afferent arterioles through blood. And that's part of what can shut off this RAA system through negative feedback. Also, blood baroreceptors is a big factor too. So the baroreceptors, the pressure receptors in those arterioles will also say, okay, we have adequate perfusion pressure now, we can shut off this process. So those would be your two big negative feedback loops, would be concentration of solutes and baroreceptors or pressure receptors. Yeah, absolutely. There's a little like self-feedback with if angiotensin 2 is produced, there may be a little bit of negative feedback back onto the renin system, but really it's not until it feels that adequate pressure and that adequate concentration that it'll completely shut down. When we look at angiotensin 2 itself, its goal is to maintain blood pressure and volume. It's going to, like I mentioned, affect those baroreceptors, those pressure receptors. It also has a great kind of side effect is that it's going to limit reflex bradycardia. What is reflex bradycardia? It's when we have a change in blood pressure or blood volume that then directly affects heart rate. So if our blood volume goes down, typically our heart rate is slower. And then when our blood volume improves, our heart rate gets faster and then will slow way down again afterwards. What this does, angiotensin 2, is it prevents us from having a major drop in blood and heart rate after blood volume is corrected. So actually continue to encourage the body to have a decent normal heart rate and not drop it down too low. Sometimes what could happen in someone who's had shock, and why angiotensin 2 does this, is if you're thinking about this from the point of low blood volume due to blood volume loss or being in shock, our body typically is going to have a high heart rate initially, and then it drops low when we start to decompensate towards death, right? Renin system is going to increase blood volume, which then is going to encourage our heart rate to go up through sympathetic stimulation. And then the body's going to say, okay, I'm safe, I'm fine, I can lower my heart rate back down. But if we haven't actually corrected the problem yet, then you can actually become bradycardic again because you only had a temporary increase in blood volume, especially if you still have hemorrhage or loss. So angiotensin 2 being around prevents that bradycardic state. So keep the heart rate fast until the whole system's turned off. That's all that reflex bradycardia means. But it's a protective system. And I always think about this system as the body is doing it to prevent from like a hemorrhagic state of shock. But when we see this and talk about it most often, it's when it's pathologic in something like hypertension or in coronary artery disease, or when we have too much cardiac output and we have blood pressure being affected. At this core, when it's doing things right, it's really effective. So then we have another factor here to consider, and this is atrial or brain, so ANP or BNP, natriuretic peptide. So these peptides, they're released from the atria, the atrial or ventricles, the brain. They're released due to increased volume, and they actually will inhibit our RAA system. So this is another area of feedback control for the renin-angiotensin synogen aldosterone system. It does this also by relaxing vascular smooth muscle via cGMP, and it will lead to increased GFR and decreased renin, increased filtration and decreased renin production. It's going to dilate our afferent arteriole. So it increases GFR by dilating the afferent arteriole and allowing more blood to pass through the JGA faster. So again, if we vasodilate and we have adequate blood volume, then you're going to allow more volume to head into the kidney at a faster rate because you're going to have less vascular resistance. So that's why in some states where you have high cardiac output, you're having a lot of strain and stress on the heart, you can measure a BNP and check a person's congestive heart failure status. Their BNP is really elevated. The body's trying really hard to control and manage that renin system that's kind of run amok. And typically in CHF, this renin system is working extra hard because over time with congestive heart failure, the heart's pumping harder and harder, but pumping less and less blood through the system. So it pumps harder and harder, and eventually the heart weakens. Then we see lower blood volume, right? And so then the renin system's trying to like increase blood volume any way it can to compensate. All of these things end up building on each other and making the pathogenesis worse, right? But it's the body's normal mechanisms of trying to correct this dysfunction. So ANP and BNP are trying to help control that process. Another one that comes into play, which we've talked about a couple times now, which is good, is ADH or antidiuretic hormone or vasopressin. This is more regulating our serum osmolality. Again, sodium and water reabsorption. Responding to lower blood volume states, it's going to stimulate that reabsorption and collecting ducts. It's also going to reabsorb urea, which I think is interesting, especially if we think about things like the urea cycle and those biochemical processes. But really, it's going to be responding to those low blood volume states. It's going to encourage our water and our collecting duct reabsorption. And then we have aldosterone. Again, this is just review. We've talked about aldosterone until we're blue in the face by, again, regulating extracellular fluid volume and sodium, increased in also low blood volume states. And it's going to increase potassium excretion, right? So it's going to lower potassium in the blood because we're exchanging it for sodium. So this can be a great treatment for hyperkalemia or a high potassium in the blood state. How's RAA? Did it. Woo. Okay, we're about halfway through our kidney stuff. It's 11 o'clock. Where are we at? Do you want to keep powering? Do you need to, like a sand break? What are you thinking? I have a power through vote. I have a 2-minute stand break. Yeah, let's do like a two. I'll keep recording. We'll just do like a 2-minute shake it out, stand up, walk around, go see sun, do a jumping jack. Whatever you need. Yeah, absolutely. Power pose. Do some yoga. Mm-hmm. Yes. Uh-huh. Which they often will, right? So in a normal healthy system, it would increase GFR. But if you're having already kidney failure, you might see ANP and BNP might be released to try to increase GFR more and more. Therefore, they'll be elevated, which is why in heart failure you can see it be elevated. but without actually really effectively increasing kidney function or
So
GFR.
Would it be even higher in
Yes.
someone with
Absolutely. So if someone has that complication with like a CAD or a CHF, you can see even higher levels of ANP and BNP because the body's trying to encourage normal kidney perfusion, but not adequately doing so. Yeah. Yeah, that's a great question. Good, good, good. Once they're back in, then we'll get started again. All right, we are back in action. Metabolic acidosis and alkalosis. How to tell the difference what happens to the kidneys. We'll also talk about what happens to the whole body. This is really 4 different states. We're going to talk about it in 4 different ways. So first, respiratory acidosis. So when our arterial pH decreases below our 7.4, we can call that acidemia. When we have a low pH of our blood and we have a high carbon dioxide level, we can see respiratory acidosis. So low pH, so acidic pH of blood, elevated level of carbon dioxide, we can see respiratory acidosis. This is when we see hypoventilation. We can see this from airway obstruction, acute lung disease, chronic lung disease, opioids or sedatives, or weakening of respiratory muscles. And your patient is going to hypoventilate to the point of hypoxia, right? So we already have a high carbon dioxide level. We can see rapid shallow respiration. So it is that they're breathing fast, but they're rapid and shallow. They're not getting good adequate oxygenation in. Your blood pressure can decrease. You can have some vasodilation. Your blood pressure will decrease. Shortness of breath, headaches, hyperkalemia, dysrhythmias because your heart rate, your potassium level is elevated. Symptoms like drowsy, dizzy, disoriented, muscle weakness and hyperreflexia because of lack of oxygenation to tissues. COPD, pneumonia, any respiratory stimuli, these can be common occurrences. And really, I think about it as a retention of carbon dioxide by the lungs. So when we're thinking about respiratory acidosis, we think about low pH, high CO2, hyperkalemia. And causes, we're thinking primarily stuff that can affect lungs or respiratory stimuli, things that can cause a depressed respiratory state like opioids or sedatives, or a weakening of those respiratory muscles. Versus metabolic acidosis, we have 2 different metabolic acidosis that we're going to look at. This first one, again, we have acidic pH, and we're going to look this time at bicarb, and we're going to say that there's a low, if we have a low bicarb state, we're going to look at metabolic acidosis. The first thing you would do is you check your anion gap. What is an anion gap? Great question. Anion gap is sodium minus the sum of chloride and bicarb. So if you have an acidic pH, a low bicarb system, and you have an increase in your anion gap, your potential etiologies, your acronym is GOLDMARK. Okay, glycols, oxoproline, that just means chronic Tylenol use or overuse. L-lactate, methanol, so any of your alcohols. Aspirin, renal failure, and this is ketones, not ketones. It's ketones, put a little E in there. Like, what the heck's a ketone? Doesn't exist. Ketones. So ketones, we can see that in like diabetes, right? We could see diabetic acidosis. So any state where you have elevated ketones. So when you're in a metabolic acidotic state, you have an accumulation of acids. You can see some etiologies here: uncontrolled diabetes, starvation. You have those ketones we talked about yesterday are beta hydroxybutyrate acetoacetate, so diabetic ketoacidosis, or in hypotension, hypoxia, you have impaired oxygen delivery. You can see in the renal system, you can have issues with our carbonic anhydrase, which is our bicarb system. Maybe you have an inhibitor that's preventing us from creating bicarbs. You get low bicarb. So you don't have a good buffer. In our kidney, right, we exchange hydrogen ions, but we do that with bicarb, that feedback loop. So if we have a carbonic anhydrase inhibitor, we're not able to do that. We hold on to more hydrogen then, we don't excrete as much in the urine. So then you get proximal renal tubular acidosis. So this can occur all over the body. So I don't want you to memorize every condition that this can occur in. I want you to recognize the state. So if you hear things like low pH, you know you're going to be in an acidotic state. Then you're identifying, is it respiratory in nature or is it going to be more metabolic in nature? You could see both. Respiratory, you're going to see high CO2 or high bicarb. Metabolic, you're going to see low bicarb, and then you're looking for anion gap. Is my anion gap low, or is my or increased, up, elevated, or normal? So this is elevated. We're looking for things like alcohol, substances, aspirin, chronic Tylenol, kidney failure, or our like diabetic acidosis from ketones. You can also see acidosis though with no anion gap change. So this is the same exact picture, metabolic acidosis, but instead your anion gap is normal. So your ratio of sodium to chloride plus bicarb is normal. It's not elevated. This is when hard asks is your acronym. You can come up with a different one. But hyperchloremia, so elevated chloride. Addison's disease, so an adrenal insufficiency, low cortisol. Renal tubular acidosis, so that localized acidotic state, maybe due to a carbonic anhydrase inhibitor, having trouble exchanging that hydrogen ion because we don't have a bicarb buffer. Diarrhea, so if you are having massive blood volume loss. Acetazolamide, the drug. Spironolactone, another drug. Or salt infusion. Saline infusion. Symptoms, similar symptoms. You might see muscle twitching, nausea, vomiting, headaches, low blood pressure. Your muscle tone and reflexes are going to decrease. You can have these Kussmaul respirations where you're kind of like, it's not a full breath. It's compensatory hyperventilation. So again, those shallow, not helpful breaths. Elevated, so anything that's going to increase hydrogen production, anything that's going to decrease hydrogen elimination, anything that's going to decrease bicarb production or increase bicarb elimination. Those are your etiologies. Hold on. Oh, good. Okay. So on the other end, respiratory alkalosis. So alkalosis, right? Elevated pH. So we're now in a basic state. Respiratory alkalosis, we have a low carbon dioxide system. We can see respiratory alkalosis. We see true hyperventilation here. It can occur from anxiety or panic disorder, hypoxemia, salicylates, tumors. That's pulmonary embolism, PE, and pregnancy. So we have true hyperventilation, meaning we have increased rate and depth of breaths. We're trying to increase our carbon dioxide in our respiratory system. We have tachycardia, decreased or normal blood pressure, hypokalemia, so opposite of acidosis, hyperreflexia, muscle cramping, seizures, and more irritability. Versus metabolic alkalosis. So again, high pH, high bicarb system. You'll want to check urine chloride. If chloride's high, we call that saline resistant. If chloride is low, it's called saline responsive. That just helps with treatment, but it can also help you with etiology. So high chloride saline resistant states of metabolic alkalosis can be from hyperaldosteronism, Bartter syndrome, Geiselman syndrome, low chloride states, vomiting, drugs, really like your diuretics, your antacids. And you're feeling this restless feeling followed by severe lethargy, heart arrhythmias, compensatory hypoventilation, maybe dizzy, irritable. All these kind of make you feel dizzy or irritable. All of these can cause nausea, vomiting, diarrhea, and tremors, muscle cramps, fingers of toes, and hypokalemia. So again, hypokalemia and metabolic alkalosis and respiratory alkalosis. You can see hyperkalemia in your respiratory acidosis and metabolic acidosis. When I see these questions, I know the next question you're asking, when will we see these questions? When I see these questions, I've almost always seen them in reference to diabetic acidosis, talking about excessive ketone production, and questions regarding pH, bicarb or CO2 or oxygen level, and potassium. So telling us what's going to be high or low. So if you're able to know, kind of reason your way through that type of a statement, you'll be fine for this type of a question. Also sometimes used in someone who's like, this patient, you had a patient with gastroenteritis, they got exposed to salmonella, so maybe they'll ask you some micro questions and they throw in like, they've been vomiting and have had diarrhea, and you suspect that they're, how would they word this? You suspect that based off of their past medical history and their low potassium status, you suspect what? Metabolic alkalosis and hypokalemia, metabolic acidosis and hyperkalemia. So those type of questions where they will give you a couple of those answers. I think typically in diarrhea and vomiting states or diabetic acidosis has been the two ways I've seen this used the most. NPLEX 2, I've seen it more with drugs, but NPLEX 1, those would be the two areas. You may get a respiratory acidosis question if you had a lung pathology question or a lung pathology state. I haven't seen that used as often, so I think that's more rare. Diabetes 1, diabetic acidosis is just too easy. So if they can go there, they will. Too easy. Okay. All right. How are we doing? Yeah, okay. We're gonna do some nephritic and nephrotic syndrome stuff. So a little bit of kidney pathology. This is the area of a lot of the stuff with the kidney can be pretty straightforward. You're looking at your UTIs, you're looking at your chronic kidney disease, you're looking at your kidney stones, those things you can kind of, some of the congenital stuff. But when it comes to nephritic and nephrotic, there will be many questions, I tell you. And it's always just a game of minutia. So that's why I want to go through these two syndromes. We're going to separate and define them, talk about a couple of the specific types of conditions that can fall into either category, and hopefully give you a place to start from when it comes to trying to remember the difference between the two. But really at the baseline, nephritic syndrome, you can think about it as an inflammatory syndrome. So think about, when you think about inflammation, or when you think about nephritic syndrome, think about inflammation. When you think about nephrotic syndrome with an O, nephrotic, I want you to think about massive proteinuria. Now, both can have proteinuria, but when you think of nephrotic, I want you to think massive proteinuria, gross proteinuria. Nephrotic, inflammation, nephritic. If we had to do one defining term for each, that would be my defining term that I'd hang my hat on. So nephritic syndrome can include your acute post-strep glomerulonephritis. So that's in there. Progressive glomerulonephritis, Brugger's disease or IgA nephropathy, and Alport syndrome. The big ones that they want you to know, they'll want you to know Brugger's, they'll want you to know Alport, and they'll want you to know, in general, know infective glomerulonephritis. Nephrotic syndrome, focal segmental glomerulosclerosis. I have the hardest time with this word. I apologize. Just struggles. Sclerosis, membranous nephropathy, minimal change disease. Ironically, not on your study guide. These ones. Amyloidosis, diabetic glomerulonephropathy. This one's nice to know, just as a complication of diabetes. But the big one that's on your list, they want you to know the nephrotic syndromes. We want to know in general what classifies a nephrotic syndrome, and then specifically sclerosis. That's the two kind of that are on your list for your study guide. And then you have 10 conditions that can kind of play both directions. So diffuse proliferative glomerulonephritis and membranoproliferative. They can kind of play both directions, be both nephritic and nephrotic. So we'll define what is a nephritic syndrome next. So like I said, nephritic syndrome is an inflammatory condition. Your etiology in general, sorry, take a drink of my adult chocolate milk, it says coffee in it. You're gonna have some inflammation locally to the glomerular structure. And then that basement membrane present is gonna have damage due to that inflammatory state and inflammatory markers. Going to lead to loss of red blood cells in urine and hematuria. So that's why nephritic syndromes, one of their clinical characteristics that's different is hematuria and RBC red blood cell casts. Different from nephrotic. So nephritic syndrome, hematuria, red blood cell casts, because your basement membrane is being damaged, you're actually sloughing off red blood cells. You also see oliguria, azotemia. You'll see hypertension, and you do see proteinuria, but it's low. So small amounts of proteinuria, it's not gross. So I would cut that off completely, but they definitely will ask a question. They'll be like, the patient has proteinuria and RBC casts. And if it's RBC casts, it's nephritic. If they say proteinuria and waxy casts or fatty casts, that's nephrotic. But they will throw proteinuria in with nephritic to try to kind of trick you into picking it. So there is proteinuria, but it's small. It can cause increased renin release, which is why it can lead to hypertension. So that's the pathophys behind the hypertension as a part of this syndrome, is it will stimulate renin release, which stimulates the RAA pathway. So examples, like I mentioned already, are infection-associated Goodpasture syndrome, IgA or Brugger's disease, Alport, and membranoproliferative, which can be both, but tends to be a little bit more nephritic than nephrotic. So for infection-associated glomerulonephritis, the three things I want you to know about it, it's a type 3 hypersensitivity reaction. In children, group A strep is your most common etiology. In adults, it can be staph or group A strep. If you remember those three things, you're going to be fine. Yes. No. Not for IgA nephropathy, but yes, for infection-associated glomerulonephritis, it's a type 3 hypersensitivity reaction. So you create, if you remember, for a reminder for myself, type 3 is hypersensitivity reactions or formation of those antigen-antibody complexes, those immune complexes that can stick then and muck up different parts of the tissue. So specifically in the kidneys, if we have those antigen-antibody complexes, they're relatively large. And if they're infiltrating into the glomerular structures, they're going to clog up those tissues and structures and decrease their ability to do all the things that they do, to filter out all those good proteins and glucose and all of the processes our nephrons do. They can lead to localized then nephron destruction. Other tissues they can affect is like skin, joints, and blood vessels, but specifically kidneys. I like to think though, in general, anywhere there's like small vasculature, there could be an effect from a type 3 hypersensitivity reaction. This one's happening obviously locally at the kidney first, so it's going to affect that area initially. And the immune complex that's activated initially, which will come into turn, this will make a little bit more connection sense on Monday, is our complement pathway. So an innate component of our immune system. That's initially the first part. And then we create these antibody antigen complexes. But it starts with the complement cascade. Another example of like a type 3 would be SLE, lupus. So lupus is another type 3 hypersensitivity. Type 2 hypersensitivities look very similar. We'll go through and break down type 1 through 4 on Monday, just for a reminder for us. Okay. Good pasture syndrome, I believe I have a slide on good pastures. Yeah, so good pasture syndrome, different, I think I listed it, yep, different than infectious associated glomerulonephritis. Yes. Yeah. I think I have it listed somewhere. If not, I'll add it in on Monday, but I'm pretty sure I feel like I remember writing a slide on good pastures that I've, who knows at this point. All right. IgA nephropathy, Brugger disease. This one you'll see episodic hematuria. Again, it's a nephritic condition, so hematuria occurs concurrently with some type of respiratory or GI infection. IgA is secreted by mucosal linings. That makes sense, right? GI infection secretes the IgA. Then we have this nephritic kind of process. You can see a similar antibody antigen complex mucking up the system. We're seeing episodic hematuria that's occurring. If you like a little comic, so I made this little thing here for you guys. Alport syndrome also on there. This has a genetic component, so it's a little different than the other two. This is an underlying mutation of your type 4 collagen. You'll see irregular thinning, thickening, and splitting of the basement membrane. So that's how you're still getting those RBC casts. You're still having hematuria. It's affecting that basement membrane, but it's because the actual collagen present there is thin and splitting and breaking down due to a genetic mutation. It's X-linked dominant. And the classic kind of clinical presentation is can't see, can't pee, can't hear, B. So it affects your vision, affects your hearing, and it affects your urination. So X-linked, sex-linked, more common in men versus women. We remember genetics XY, XX. We have a chance to, even if we inherited it from one of our parents, we have a chance to not inherit the, I believe it's recessive X-linked. That's why you'll see it more in men. Maybe I don't have good pastures. If I don't, I will put a slide up for you. Nephrotic syndrome, massive proteinuria. So again, I said inflammation for nephritic. Nephrotic is massive proteinuria. So with our nephrotic syndrome, we're going to see podocyte damage, so local cell damage, which is going to then impair our charged barrier and lead to protein excretion through the urine. Typically, we see this associated with a hypercoagulable state because we also are going to see antithrombin 3 loss in urine. So we see, you can think about if our barrier itself, our filtration barrier, that charge is disrupted, You can think about it holding less protein in. It's going to allow more protein to escape through urine, which is why you have proteinuria. And if it's allowing more protein to escape into the urine, it's going to allow some other components, other proteins or molecules to escape as well. So antithrombin 3 being one of them. You don't see hematuria, red blood cell casts typically with this syndrome. You'll see edema, you'll see hypoalbuminemia, you'll see hyperlipidemia, increased cholesterol, and then specifically in urine, frothy urine with fatty casts. So if you hear a fatty cast or a frothy urine, think nephrotic. If you hear RBC cast or hematuria or bloody urine, think nephritic. There's primary and secondary etiologies, and there's ones that people have both. So the secondary etiologies that are important to know is amyloidosis and diabetic glomerulonephropathy. The boths are the focal segmental sclerosis, minimal change disease, and membranous nephropathy. On your list, they want you, like I said, again, to know nephrotic syndrome, and then they have glomerulosclerosis, and then they don't have these other conditions on there. But they do want you to make sure you understand nephrotic syndrome as a whole. So sclerosis, this is idiopathic or can be due to something else like HIV, sickle cell, drug use, congenital issues, and your long-term complication is chronic kidney disease. Essentially, you have sclerotic change to the tissue. It causes all the same things with nephrotic syndrome, but the big piece of the puzzle there is the etiologies that I'd want you to keep in mind. So this would be in a patient who maybe is immunocompromised or has sickle cell anemia. They might ask, what is a complication of the kidney for sickle cell anemia? Glomerulosclerosis would be an answer. They might ask, your patient has chronic kidney disease, and they have a history of heroin use and obesity, and they're noticing fatty casts in the urine. What do you suspect? They might list nephritic syndrome, nephrotic syndrome, glomerulosclerosis specifically, and good pastures, whatever. And your answer would be glomerulosclerosis, the most specific possible. Nephrotic would also be right, though, right? And they'll do it. So go as specific as you can if you know that that's the right answer. I know those annoying question writers, we hate them. So good pastures, just to clarify, is type 2. Type 2 looks like type 3. We'll define them all on Monday. We do immune system, and it is nephritic as well. Typically, basement membrane is affecting. And then the key piece with good pastures that makes it almost a pulmonary condition is you can see pulmonary hemorrhaging as well. So when I think of good pastures, I don't just think of peeing urine, I think of also hemoptysis. So that tends to be fatal if not treated. That's it. We did it. We got through the kidney. My gosh. Yes. Yes. Nephrotic syndrome, no, not characterized as increasing renin production. So nephritic syndrome is more associated with that hypertension and renin increase. Nephrotic is not associated in the same way. Nephrotic syndrome, if you think about it, is destroying that basement membrane, or is just not destroying the basement membrane, but destroying the podocytes and increasing its ability to get rid of proteins, get rid of structures through the filtration device. Versus in nephritic syndrome, you're destroying the basement membrane and almost shutting down the glomerular apparatus itself, which is going to increase, you're potentially going to see then lower blood volume because you're having less filtration. So the body signals that to the body as a lower blood volume state because you're getting less filtration through, even though you're only having less filtration because you're damaging that basement membrane and you're not actually allowing adequate blood flow. Then they'll stimulate renin increase to try to increase blood pressure because it thinks that it's an issue with blood volume, when really it's just filtration status. You can see low GFR with both potentially because your body's not filtering effectively for either. you'd see GFR get lower faster for nephritic versus nephrotic, because nephritic syndrome typically has a more direct effect with overall filtration rate, blood flow moving through. But in nephrotic syndrome, you'll have eventually the same results. So you can see chronic kidney failure in both. Does that kind of help separate a little bit? Yeah. Yeah, absolutely. Awesome. Okay, so what I have now, we have 29 minutes, which I set up today to be that way in case if you all were just done. I'm okay with that. I have some worksheets to go through and some questions and some cases that we can go through here and online. If you don't want to do the active participation portion of the day, you can just sit passively and listen, or you can take off early. I'm fine with either or. But I wanted to leave it to you all to see what your level of engagement was. Would you rather do multiple choice, like 1, 2, 3, 4 questions? Or do you want to do like labeling, writing, kind of that type of discussion type stuff? What seems easier right now? I have a vote for 1, 2, 3, 4. I have 2 votes for 1, 2, 3, 4. Any? 1, 2, okay. So 1, 2, 3, 4 feels easy right now. Yeah. Okay. Good. I posted my anatomy study sheets. The first page is unlabeled with a list of stuff to label. The second page is the answers. I have tons. So if these are helpful, I can make a folder of these for y'all to use for anatomy study. Yes. Okay. So I'm going to work on first, my priority is to upload all of the recordings for people who want to listen to it again. And then over the weekend, I will create just a section that is like anatomy review pages. So I'll take it out into your daily folders and it'll just be like anatomy review. So if you want to do the fill in the blanks, then you'll have that. Does that feel good? Yeah. Okay. Yeah, totally. I have so much study materials. It's just not overwhelming you with the amount of things I have. So that's why I don't put it all on the Moodle page. But if you want it, I probably have it somewhere. Great, awesome. Okay, yeah, anatomy is a beast. We don't do a ton of anatomy lecture in this class because it's just a lot of like repetition and memorization, which is really boring to lecture on. Like this is the vasculature of the blah. But I do encourage you to spend some time like mapping, drawing, filling in the blank. That will be probably your best review you can do for anatomy. Yeah. It's a trek. Yes. Yes, agreed. Yeah, I was a cadaver prosector dissector when I was here. So it used to be Dr. Naya was the anatomy instructor here, and I was his main prosector. So for me, if I could see it, I'm like, oh yeah, I can I've dissected this, I got this. But then when it came to identifying the words, I was like, whew, I don't know. A lot of words here. Okay. I would say I studied anatomy somewhat. I definitely didn't probably study it as much as I maybe should have, but it didn't matter. Okay, digestive or kidney? What one do we want to do? Digestive? Okay, we can start with digestive and see. We might be able to rapid fire through these digestive things. It is made in the state of Jeopardy again. So sorry if you hate Jeopardy. That's what it is. Okay. And online, folks, you might actually see the answers before everyone in class does. So don't give it away. I don't know if they might be able to just see the screen, but if they can see my instructor's screen, they might be able to see the answers. Okay. All right, we'll just do it like yesterday. We'll call it out and we'll go through the questions. Some of these questions are easy. Some of them are more difficult and minutia-ish. All of these are potential NCLEX questions that have been made into, I use Pearson's like Jeopardy tool, and then I add in our NCLEX questions. So that's what this is. Okay, so where do we want to go first? Intro 100, I love it. All right. Peristalsis is part of what digestive process? Absorption, ingestion, propulsion, chemical digestion. Peristalsis, absorption, digestion, propulsion, chemical digestion. Awesome. I'm seeing a couple different answers. Good, good. You said propulsion, you're correct. So peristalsis is propulsion, moving things along the digestive tract. Does it help with absorption? Yes. Does it help with ingestion? Yes. Does it help with chemical digestion? Yes, but itself is defined as propulsion. All of the following are part of the alimentary. Oh wait, that's you didn't get to choose. Sorry, you didn't get to, you choose now. I got so excited. What next? Woo. Okay, small intestine 3. The substance secreted by the pancreas helps neutralize chyme, chymotrypsin, bile, trypsin, bicarb. What helps neutralize stuff? Chymotrypsin, bile, trypsin, bicarb. Yep, bicarb. When in doubt, if it says neutralize something, unless if it's a bacteria that you're neutralizing, it's probably bicarb is probably a good choice. What next? Upper GI4. Which of the following phases of gastric secretion is a conditioned reflex? The gastric phase, the cephalic phase, the intestinal phase. All three phases are conditioned reflexes. Ooh, this is tricky. Gastric, cephalic, intestinal, all. You said cephalic. You are correct. So what is a conditioned reflex? Yeah, so it's actually something that is a physiologic reflex that controls the motility of this gastric secretion. So when we think about gastric secretion, which one is a reflex? Which one responds to something else? Cephalic phase, the gastric and intestinal phase, these would be more associated with increasing stomach acid and then increasing pancreatic enzyme, versus cephalic is actually the reflex of emptying. Okay, conditioned reflex. All three phases are not conditioned reflexes. We can also think of a conditioned reflex as an autonomic response to a stimulus. Which one's autonomic? Cephalic phase, autonomic. Classical conditioning. All right, where are we going next? 2. What specific process is mostly used to absorb water from the intestine? Simple diffusion, active transport, osmosis, filtration. Water. Good. Good, maybe, not sure. Good, every answer's up. I love it. Osmosis. So when in doubt, when dealing with absorbing water, think osmosis, right? Now, is diffusion a good answer potentially? Absolutely, right? Diffusion is just going down a concentration gradient, which osmosis is simple diffusion using just water, right? So when I think of water absorption, I think of osmosis, simple diffusion, moving without needing any energy input, active transport, you have to put in some energy. So most of our ion stuff like sodium, potassium is active transport. And then filtration, like think kidney, right? We're filtering stuff through. Good. All right, what's next? Woo. Love it. The pocket-like sacs of the large intestine are called, here's some anatomy. You wanted it, now you get it. Okay, Tenei coli, hostra, epiploic appendages, or ceca, or cecae. So think, what's a pocket-like sac of a large intestine? If you have no idea, take your best guess. I see some answers there that are correct. I'm excited. I see some guesstimations probably, which is good. So haustra, if you were thinking haustra or hostra, you're correct. So what does that look like? I'll get you a picture. There's the small little outpouches caused by sacculation. They give that segmented colon appearance. So if you think about the colon kind of having those segments, it's due to haustra. You can see it here. It's very small, but you can see it. Those of you online won't be able to see it, but you all will. The little outpouchings, right? The little cute pockets. Haustra. Yep, exactly. A little segmented, almost like we get like a worm, right? Or centipede. All right, what's next? This is why I did this one this way, because I know we aren't getting a lot of anatomy. So that's why we have some anatomy questions here. This is how you could see anatomy questions worked into the gut. Upper GI 2. The esophageal hiatus is found in this organ: esophagus, stomach, diaphragm, pharynx. So we first have to know two things, right? What the esophageal hiatus is, and then where you might find it. Woohoo, found a lot. Yes, diaphragm. So diaphragm and esophagus would be my two guesses, okay? Esophagus, because when in doubt, most of the time when it's something obvious, it's the obvious answer. But in this case, the esophageal hiatus is found on the organ of the diagram. So what is the esophageal hiatus? Let me show you a little picture here. Maybe I don't have a good picture. Oh, so often I have really good pictures right there. I don't have a good picture, but how I remember this one for myself is I think of hiatal hernia, and I think of hiatal hernia as being the outpouching of the stomach, above the diaphragm, et cetera, et cetera. So the first thing that it would contact before getting up above my lower esophageal sphincter into my esophageal tissue would be the diaphragm. That's how I remember that. I just think esophageal hiatus is a hiatal hernia. That's just what I've made in my brain. I know it's not, but that's how I remember it. All right. Oh, nope, we don't care about saliva yet. Okay. No, you didn't see it. Oh, all right. Choose an option. No one saw that. Which histological layer of the alimentary canal is also known as the visceral peritoneum? Histology. Oh no. Visceral peritoneum. We have some thinking. We have some guessing. We have some no answering yet. Oh, good. Everyone's answering now. Awesome. Serosa. So if you said C, you are correct. So, okay. Histological layers of alimentary canal known as visceral peritoneum. So let's find the alimentary canal here. Maybe I can get you a good alimentary canal. And then we have the serosa. Okay, I'm gonna get you a picture. Where's the picture? Picture. Okay. This picture sucks. Okay, I'm just lying to you all the time. I'm not getting you pictures of anything. I will get you, with your anatomy review sheets, I will get you pictures of these things, okay? Because I'm not doing a good job of getting you pictures on my laptop that no one can see. But serosa is the correct answer. So if you chose that, you were correct. All right, who's next? Or what's next? Large intestine 4. Which of the following reflexes are we able to voluntarily control? The gastroileal, the gastrocolic, the enterogastric, or defecation? Which one do you know we can control? And then choose that answer. This isn't a healthy person that doesn't have pathology. We'll say that. Your defecation reflex, right? We know we're not pooping all over the place. We know that we can normally. We know that we can control that reflex at least once we become adults. As kids, we're not able to as much. Great. All right, what's next? Okay. Which of the following is not an enzyme? Renin, lipase, pepsin, bile. Renin is supposed to be spelled with one N. So that is normal renin. Renin, lipase, pepsin, bile. Which one's not an enzyme? Good. I'm seeing some answers. Bile, correct. Yep, renin, lipase, pepsin. We know all of those are used in enzymatic reactions. Renin's the one that trips people up the most, but renin, remember, secreted by the kidneys, converts angiotensinogen to angiotensin 1. Its whole purpose is an enzyme. Bile is not an enzyme. All right, where to? Small intestine 5. This hormone relaxes the hepatopancreatic sphincter. Is it cholecystokinin, CCK, secretin, gastrin, or bile? Who relaxes the hepatopancreatic sphincter? And my other thing I would say is who allows other pancreatic enzymes to be released? That might be a good hint. Most of you are already on the same page. Yep, CCK, absolutely. So CCK is secreted. It helps kind of get a lot of those processes started, right? It allows the pancreas to release a lot of its digestive good juices. And it helps do that because CCK actually allows that sphincter to relax. So it physically dilates the sphincter, allowing for those enzymes to come out. Great, we love that. Fantastic. Makes sense. All right, what's next? Intro 2, right. All the following are part of the alimentary canal except the pharynx, esophagus, small intestine, liver. Good, I have some answers. Awesome. You said liver, you were correct. Don't change your answers. Some of you had the right one and then you changed it last minute. Trust your gut. Now you know you're a first guess person. If your first guess was right, now you know. Liver, what is the alimentary canal? We're not sure. Good. Okay, awesome. That's why I wanted to do this. Yeah, the mouth down to the anus, right? It's the passage, or from the very simplistic view, the tube that food goes through, right? So all these things food's going to contact, yes? The food's going to contact down your pharynx, and when you swallow it, it's going to touch the back of your throat. You're going to swallow it through your esophagus. It's going to get into your stomach. Then it's going to go into your small intestine, then your large intestine, and out the anus. The liver is involved in your digestive process, but it does not actually have the food move through it. It's not the tube. So alimentary canal is everything that food's actually moving through. So other things that wouldn't be alimentary canal: gallbladder, pancreas, spleen. Yeah, I think those would be the things. Huh? Thank you. Excessive acidity in the stomach causes a what in what secretion? So you have to decide if it's going to be a decrease or an increase, and then either CCK, cholecystokinin, or gastrin. So if you have too much acid in your stomach, what is it going to do into what molecule? Good. Good. It's going to decrease gastrin, right? What's gastrin's action? Increases stomach acidity, makes the stomach more acid. So if we have too much acid, we're going to want to decrease gastrin secretion. Cholecystokinin doesn't have direct action on the acidity of the stomach, right? It's not going to be directly increasing or decreasing stomach acidity. So it wouldn't be cholecystokinin. That's why this one's tough. You really have to know which hormone or which molecule you're talking about. And then you can logically be like, if you know gastrin is going to increase stomach acidity, you say, well, I'm going to want to decrease gastrin. Great. Small intestine, 400 or 200? 200. Which of the following is not an enzyme produced by the pancreas? Amylase, lipase, nuclease, glucagonase. Well, if y'all can't guess it now, I don't know who could. It's gluconogase or gugase or whatever word I couldn't say. Nuclease is actually produced by the pancreas. We didn't really talk about it because it's not really something that's commonly used, but it is produced by pancreas. So I would say this is probably a bad question. Instead, maybe we would say protease, right? Amylase, lipase, protease, and gluconogase, right? Maybe then that would be a better question, a more appropriate question. But you did good. You chose the two that you weren't sure about, which is what you should do. You have a 50-50 shot then. What next? This one? Okay. Okay. Amylase allows us to digest carbs, proteins, fats, or all. We should know this one. Amylase, carbohydrates. Good. Awesome. What next? Great. Simple columnar epithelium is found in which histologic layer of the alimentary canal? So again, tube that food runs through. Where are we seeing columnar epithelium? Is it submucosa, muscularis, serosa, or mucosa? Think about what's in the columnar epithelium typically. There's a specific type of cell that can do a specific type of thing that could give you a hint of where it's located. Yeah. Awesome. Mucosa, the mucosal layer. Columnar epithelium will often have goblet cells which contain mucus, and so that's how I remember this one. Mucosal layer because columnar epithelial cells are long and tall, so they can house other stuff in them that can release things like mucus that can lubricate our alimentary canal. Yes, absolutely. So columnar even is extended more because it has the villi on it that can increase that surface area to increase absorption. Great. Awesome. Oh, right. Whoops. All right, back to game. What next? Large intestine 3. The functions of the large intestine include all of the following except elimination of waste, absorption of water and electrolytes, absorption of nutrients, absorption of vitamins produced by bacteria. What does the large intestine not do in this category? This one's tricky because they are very similar asking. And I've seen every single answer response, which is awesome. It is nutrients. And why this is tricky is nutrients. They should probably refer to this as macromolecules, right? So they're talking about carbs, protein, fats. Those are absorbed in small intestine because vitamins produced by bacteria could be called nutrients, right? And that's absorbed in the large intestine because that's where our bacteria are. And then water and electrolytes, those are also could be considered nutrients. And there is some absorption of that in the small intestine, but there's absorption also in the large intestine. And then elimination of waste, we know that one to be true. So I think this would be better written if it said macromolecules. But another way you could have gone through this is you could have just logicked your way through this, right? You know elimination of waste occurs in the large intestine. You know water can increase or decrease in the large intestine because that's how we can sometimes have looser or more concentrated stool. And then you know bacteria occurs in the large intestine, so that has to happen, right? Even if you weren't sure if there's vitamin absorption, the only place our bacteria are typically in a healthy gut is in our large intestine, right? Most of the time. We can have some bacteria in the small intestine, which can lead to SIBO. Anyways, but most of the time, our absorption of those nutrients happen in the large intestine. So then you're left with C. So if I was going through and confused by this, that's how I would logic my way down that list. Okay, a few more. Inter 5. The membrane that lines the body wall of the abdominal cavity is the ventral mesentery, visceral peritoneum, parietal peritoneum, retroperitoneum. Good, we have some answers. Awesome, we have a mixing. Okay, it is the parietal peritoneum, and this is why, okay? Because visceral makes sense, and that's what you would want to choose, right? Parietal peritoneum lines the body wall, the outer part of the abdominal cavity. It goes all the way down from the pelvis and all the way up into the abdomen, including the diaphragm. Visceral, think viscera, think organs. The visceral peritoneum is lining your organs specifically. So yes, both are in the abdominal category. Visceral is on your viscera, on your organs, lining those organs, versus parietal is lining the whole cavity as a massive component. Yes. The retroperitoneum, it just said retroperitoneum. It didn't even say abdominal cavity. So it's just saying retroperitoneum. When it is referred to, and let me pull this up here, retroperitoneal organs. Retroperitoneal space, you could associate this one with lining the organs that are all retroperitoneal in location. So kidneys, adrenal glands, pancreas, specifically more the tail than the head, nerve roots, lymph nodes, abdominal aorta, and inferior vena cava. So everything that if you did like a slice through the body everything that's backward, more retroperitoneal. The retroperitoneal, I guess you could say viscera, would be lining that region. But the whole cavity as a massive component would be lined by the parietal peritoneum, and then the viscera is just lined by the visceral peritoneum. Most of the time, the two answers they're going to look for, ask you about is visceral versus parietal. That one's asked commonly. So that's a good one to think about. What about ventral mesentery? What's that? What's a mesentery? Yeah, absolutely. It's derived from our mesogastrium, and it helps to form the viscoperitoneum also of the liver, but it is lining kind of in between all those things. You can think of mesentery as like almost like a big confluence of stuff, right? So I always think of it almost as like a cluster of spider vein things that are complicating over each other. But ventral mesentery is kind of filling up all that space. Yeah, mesh. Whoever said mesh. Yes, absolutely. All right. We'll see if we can get through. We have 4 minutes, rapid fire. So I'm just going to go through them. So saliva is composed mainly of, we know this one now because we saw the answer. So if you're watching, mainly of water, amylase, lingual lipase, or mucin. It's mostly water and then it has amylase, right? But it's majority water. Gastric cells that secrete pepsinogen are the mucous neck, parietal, chief, enteroendocrine cells. Our chief cells secrete pepsinogen. Good. This is, again, that's that root memorization that I want you to do for those locations. Most of digestive enzymes found in the small intestine are secreted by this accessory organ. What organ secretes stuff the most? Yep, pancreas. Absolutely. Liver does a little, pancreas does the most. Hormone that triggers the release of enzyme-rich pancreatic juice. Ew, sounds gross. But what's our hormone that triggers pancreatic release and pancreatic sphincter relaxation? CCK. CCK is going to trigger all that. Rapid fire. Good, we'll put you on the spot. No, I'm just kidding. Welcome back. Which of the following is not part of the large intestine? The cecum, the appendix, the ileum, the sigmoid. Yes, the ileum, correct. Mass movement in the large intestine is initiated by the, oh man, mass movement, gastro something or enterogastric or defecation. So the ileal, the colic, the gastric or defecation reflex. Gastrocolic. I think of like colicky baby, right? Colicky baby, you can feel like the pinging on their belly when they're colicky. And so it's that pinging, that movement. So I think about, oh, the colicky baby, it's intestinal movement. That's how I remember it. It works. Doesn't make any physiologic sense, but it's in my brain forever. Where does chemical digestion of lipids start? This one, I somewhat disagree with, but choose your best answer. I disagree with what their answer is. I'll agree with your answer. So it says mouth. And why I don't love that answer is because there's really no lipid digestion in the mouth except for mastication. And so that's why it's correct. Yes? Lingual lipase. Yeah, lingual lipase counts. That's true. Lingual lipase counts. But I'd say if we're going to talk major digestion of lipids, where's the major action going to happen? Where does our major lipid lipase come from? Pancreas, so small intestine would be the majority of digestion. But if we're going to talk beginning, mouth probably is fine. So in theory, with that logic, lingual lipase, carbohydrates, we could say mouth. Proteins, we could probably just say stomach, but if we're going to count mastication, mouth, right? So those are a little tricky. So it depends on what they're asking for. It says chemical digestion, and so we would count lingual lipase. We would count it. Micelles, oh, whoops, did we do this one already? Well, you saw it all. Micelles are formed during the absorption of which nutrient? I got so excited. Fatty acids, we know this. And then last but not least, final round. Oh, good. We'll end on a strong one. Intrinsic factor. We know this. We love it. What vitamin? And then last bonus question. What anemia can you have if you don't have adequate B12? Pernicious. And what type of cells do we see in a B12 anemia? Big megaloblastic or a macrocytic anemia. Good. Awesome. All right. You made it through gut, you made it through kidney. I will post those anatomy pieces in a separate folder onto your Moodle page for anatomy review. Monday, immuno, micro. I would bring a piece of paper if you can. I'll have some here and your favorite writing utensils. We will be doing a dichotomous T together to remember our bugs. And then we'll get through the rest of the week. I'll update the schedule to reflect kind of what we're doing. So we've covered some stuff already and we'll go from there. Enjoy your weekend. Woo woo. Thank you everyone online. I'm gonna stop sharing. I will work on posting these when I get home in an hour.
Thank you.
Today we had